Welcome back to the Lift Free and Diet Hard podcast. I'm your host, Andrew Coates. Join me along with industry leaders and friends on a quest to get more people through the gym door and eating and living healthier. Join me where evidence meets empathy while rejecting fitness industry fads and extremism. Let's begin. Dr. Karl Nadolsky. And if that surname sounds familiar, yes, brother of Dr. Spencer Nadolsky. You guys are the docs who lift. You co-host that podcast. Spencer's been on a handful of times, including recently, and he's an old friend. But you're a physician, an obesity specialist. But here's the big one. You're an endocrinologist, which, oh boy, people talk a lot about hormones in the fitness industry nowadays. And you got a full-time job dealing with that stuff. So we'll go there. Welcome to the show. It's an honor to finally have you. It's long overdue. Thanks. And let's start here. Is adrenal fatigue real?
Adrenal fatigue itself as a disease state is not a real thing. It's, it was a term that's coined by a guy named James Wilson back in many years ago. He wrote a book on it, the 21st century stress syndrome. But unfortunately I think some of the premise was, okay, I guess. But we know a lot about the adrenal glands, the hypothalamus, the pituitary, and the adrenal axis, what the different hormones from the adrenal gland do. And we know a lot about a real adrenal insufficiency, which is a big deal. It's not a minimal thing to talk about. It's a big deal. We know a lot about the different adrenal hormone excess, ranging from excess cortisol, called Cushing's syndrome, aldosterone excess, which I explain to patients as our blood pressure hormone. One of the other cortices of the adrenal gland makes DHEAS, or DHEA, which is kind of a low, mild potency androgen. And then the middle, the medulla of the adrenal glands make what people kind of think of as our adrenaline, like our norepinephrine, medinephrine, stuff like that. And so, we have a lot of studies over all the years and more that keep happening to help us diagnose essentially adrenal insufficiency and also cortisol excess, which is really what adrenal fatigue gets into it. The concept is that chronic stress, which does cause excess cortisol. It causes our hypothalamic pituitary adrenal axis to engage and increase cortisol, which people, of course, think, oh my God, that's really bad, but it's actually really good. That's what it's supposed to do when we're under stress. And then the thought behind this was that, we're under so much chronic stress, now our adrenal glands can't keep up and we're fatigued. But if you had true adrenal insufficiency, which again, we can diagnose that, and it's due to actual destruction of those cells, then that's big time problems. And we can diagnose that for sure.
And influencers are not going to cure that with supplements. We can come back to that after. But okay, so let's go even deeper. You talked about fatigue, tired. What are the symptoms that the everyday person is having that have been usually attributed to that umbrella term of adrenal fatigue?
Yeah, so it's interesting. So the people that will sell the supplements for this will say, do you have these symptoms? Do you feel burned out? Do you have ADD or ADHD, fatigue, depression? Are you sleepy? Do you have fibromyalgia, headaches, stress? Are you struggling with weight? All these different things. So many different symptoms that a lot of people struggle with for a lot of different legitimate reasons. Symptoms are real. It doesn't mean that made up diagnosis is real. And so from a physician's perspective, what we need to do is we need to acknowledge patients. And I think one of the problems has been that, these people sell this term and they think, oh, that's the secret sauce. You know what I mean? That's got to be what it is. And then they get sold supplements. And then sometimes what happens is at the same time they're buying supplements, they're also improving their nutrition, their exercise, their sleep, and their stress reduction, which is the issue most of the time. And it gets better. So they think, oh, right. So my, no offense to the chiropractors who don't get into this quackery stuff, but, a lot of times it's a chiropractor or naturopath. There are plenty of, quack physicians that push this too. And they think, oh, yes, they're right. They figured it out. but really they just tricked them into buying supplements while also appropriately improving all their lifestyle aspects. Now, in the real medical world, though, what I think is as important is making sure we address the real symptoms of fatigue, not only address the lifestyle factors, but make sure there's not a real, which by the way, could be legitimate adrenal insufficiency. But again, a lot of the symptoms with adrenal fatigue don't really fit exactly.
Okay. So you clearly stated it, but again, working out, sleep, better nutrition, these are still your big rock drivers that improve most people's experience, right?
They are the absolute most fundamental, important things everyone has to work on. And I think it is difficult in medicine because so many people struggle with those problems that it's sometimes hard to tease out real pathology, meaning like a real disease process that doesn't have something to do with those. You know what I mean? So yeah, a lot of what we can fix, or a lot of our problems can be fixed with improving nutrition, exercise, sleep, stress reduction. First of all, that's easier said than done, right? So I talk about that all the time with patients that I'm like, well, geez, I wish I had a better magic wand to help you with your stress reduction, but when we figured out together, let me know, because that's hard in our society. It's important. It doesn't mean it's easy to do though. But we as doctors also then need to make sure you don't have an actual adrenal disease. You don't have thyroid disease. You don't have other, in my world, hypothalamic, pituitary, other hormone diseases. You got to make sure you don't have anemia. When people are fatigued and falling asleep all the time, despite they think getting enough sleep, do they have sleep apnea of some version or other disordered sleep issues? So the symptoms are real, and we have to acknowledge that for patients. Otherwise, they then say, oh yeah, see, now they're dismissing me. And unfortunately, that happens a lot because our healthcare system is so dysfunctional that they don't allow doctors to have enough time to sit and talk it out with patients. And so then when people come in and say, hey, I need to be treated for my adrenal fatigue, a lot of the doctors are like, I don't have time to talk about this fake diagnosis. And then they dismiss them. And then that just causes a vicious cycle, I think. And I'm not dogging other doctors either. It's a lot of that comes down to our dysfunctional healthcare system. I tend to blame insurance for a lot of that, but that's a whole different podcast discussion. And I guess I'm just saying, for patients, know that your symptoms are real. Talk about your symptoms. Don't be fooled by people trying to sell you adrenal fatigue and the supplements, but also talk to your doctors about the symptoms and make sure you're getting a legitimate evaluation into what they are. And yeah, it might just be all those lifestyle factors. Again, easier said than done to fix them, but we can't just dismiss other real medical problems either that we have to figure out and treat potentially.
And I guess one of the big dangers of if a physician dismisses the person based on the label, well, where are those people going to go? To the person who's going to validate the language, which is the quack figures that are selling the bullshit.
Yeah. And then what happens if there is a very serious underlying medical problem, then those things get missed. And sometimes it's really serious. I mean, just imagine a relatively simple thing that we've heard of happening is somebody is legitimately fatigued and they go and they get told they have adrenal fatigue. They buy supplements. Let's say it doesn't work. Their diet, exercise, sleep, all that stuff doesn't work. And it turns out they have a very severe anemia from colon cancer. That's bad, and talk about like real adrenal insufficiency. So if somebody gets sent to me for severe fatigue, if their adrenal glands themselves don't work, so that we call it a primary adrenal insufficiency where the adrenal cortices don't work. So essentially the cortisol secreting cells, the aldosterone secreting cells, and the DHEA secreting cells, people will have pretty profound fatigue. It's most often caused by autoimmune disease, at least when it in of itself is diseased. But there can be hemorrhages for whatever reason. There can be, especially in other parts of the world, tuberculosis or other infiltrative diseases. I think I had, I have some patients who've had metastatic cancer to their adrenal glands and now they don't work. They have profound fatigue. They have low blood pressure, lightheadedness, and actually, contrary to a lot of the adrenal fatigue stuff, they actually lose weight inappropriately. So they're like really losing excessive weight. And actually, they often get a tan, even in the wintertime, And that has to do with the negative feedback to the hypothalamus producing the cortisol stimulating hormone, which is called adrenal corticotropic hormone. And that also ends up increasing the melanocyte stimulating hormones, the cells in your skin that make our pigment, so you get darker. That's a primary adrenal insufficiency. Secondary is when something's going on with the hypothalamus or pituitary. The most common cause of that is actually medication. So when people take steroids like prednisone that mimic our cortisol, right? So it could be hydrocortisone, prednisone, dexamethasone. Those are our anti-inflammatory steroids. Those are the most common cause of Cushing's syndrome, which is the body's response to excess cortisol or excess corticosteroid, which is what we're talking about. But then at the same time, it causes the hypothalamus, pituitary, and adrenal glands to essentially take off. They don't have to work anymore. So then that results in secondary adrenal insufficiency. In that case, it's not as profound. The symptoms aren't as profound. They don't have the aldosterone deficiency because that's actually stimulated by hormones from the kidney. But they can be pretty fatigued. They can still have some electrolyte abnormalities. They just feel like garbage. Another medication that causes that are opioid pain medicines. So opioids can suppress our hypothalamic pituitary stimulation of the adrenal glands, in addition to, by the way, a common cause of hypogonadism or low testosterone in men. So it causes a functional hypogonadism or low T in men. And so medications are very common for that. Otherwise, we worry about hypothalamic pituitary tumors or other things going on for secondary adrenal insufficiency.
So severe fatigue seems to be a big red flag symptom. Is there any, and of course, then there's this mystery tan, but are there any other things that people present with? You're like, hey, there might be something going on here that's related to adrenals.
Yeah. So when they get referred to me for that, it would be like the weight loss. They're not trying to lose weight, but they're losing weight. If they have some form of diabetes. Now, so we see a lot of people with type 1 diabetes, which is an autoimmune destruction of the pancreas. So they have insulin deficiency, and they have to be on insulin therapy until maybe we're on the precipice of it's getting somewhere with that. But generally, they're all on insulin therapy. So if they start losing weight and they start having hypoglycemia, that doesn't make a lot of sense. We think about autoimmune adrenal insufficiency because when you have one autoimmune disease, you have a much higher risk of the other ones, even if they're relatively rare. So people with Hashimoto's hypothyroidism and type 1 diabetes have a much higher risk of the relatively rare autoimmune adrenal insufficiency, which has historically been coined Addison's disease. And so that would be, so someone with type 1 diabetes comes in, they're having new weight loss and hypoglycemia. That's a red flag for me. Low sodium, so serum sodium, that has to do with the adrenal glands and the aldosterone. So the cortisol and the aldosterone effects on the kidneys. They have low blood pressure. Again, the lightheadedness. Those are kind of the most important red flags, I think.
Underlying big thing here is if you're worried about something, go check with your doctor, advocate for yourself. Let's go into that a little deeper. So, and here's something you posted. To become a real hormone specialist, an endocrinologist, doctors have to go through 4 years of medical school, 3 years of internal medicine residency, which often means working 80 plus hours a week, an endocrinology fellowship, which is 2 to 3 years, board certification exams, and then ongoing education. So what do you say about people claiming to be hormone specialists?
Well, I don't know. It must be more lucrative than the real stuff, than what the insurances pay us, because I don't know why. It's a sexy term, Hey, I obviously think it's very interesting. Going through school, endocrinology was a very difficult topic for a lot of people, but for some of us, it just made sense. All those negative feedback loops, so all these different, hormone glands speaking to each other. For some people, it makes sense. For me, it made sense. But it is otherwise, I guess, pretty difficult for some people because it's different than a lot of the other specialties. And so then the problem is, though, hormones sound sexy somehow. And so then people can use that for selling points. And so they can use it to sell supplements, sell their programs. And then, there are a lot of real doctors out there who have decided that they're going to sell hormone replacement therapy because, again, that's sexy. Now, that's a little bit more of a simple thing, because what they're doing is, unfortunately, a lot of times just selling guys testosterone. They may or may not actually need it. And menopausal hormone therapy is, while there seems to be more controversy online, and there were some issues in medicine because of the big studies of the Women's Health Initiative a long time ago, and we got a lot of kind of scary information that's coming back around. For whatever reason, that's lucrative, but it's also relatively simple for people to just say, okay, I'm going to start selling my services. And because it sounds sexy, they can somehow make more money doing that in a simpler way than, say, being an ER doctor. It's always the non-endocrinologists who start doing that. Unfortunately, they start doing it at med spas and whatever. And it's always people who don't have any specialty training. And then they claim, we're doing hormones now, but a lot of it's, menopausal hormone therapy. They're not really doing all the different hormones. There are a lot of different hormones that we have that have disease processes that need to be evaluated and treated by an endocrinologist.
This episode is brought to you by Macros First. I've always struggled with nutrition tracking apps, even the slightest hassle or friction, and it breaks my habit. That changed with Macros First. When I tried it, I told my friend, the founder, Jacob, quote, this is, let's just call it a certain other app on steroids. It's the easiest app to use, and it has a free barcode scanner, which if you use tracking apps, this is a really big deal. I recommend Macros First to all my clients and friends, and even had them sponsor my 2024 conference. Here's an example feature that I love. The verified food database. Remember using other apps and searching for a food only to find 10 to 50 similar options with different macros, not knowing which one to pick. This kind of friction is the shit that made me quit tracking altogether. Macros First, every single food item in the database, over 3 million of them, is human verified. No junk entries, so you can trust the numbers. Plus, that free barcode scanner makes logging faster. And if the barcode doesn't turn anything up, just point your camera at the nutrition label and Macros First will extract all the nutrition info instantly. All this just makes tracking easier. And while Macros First's premium version is incredible for any user, the basic version, which is nowhere near basic, is free to use. So you can go to either the Apple Store or Google Play to download. I had Amanda Thebe on a while ago. And Amanda is a great resource. She herself is not a physician, but she's plugged into the best physicians at evidence-based figures. She's close with Dr. Jen Gunter, who from what I understand,
they're both in my circle. Absolutely. Yeah.
And Jen would be probably the preeminent now, because there's some other high-profile women who've branded around menopause, including medical doctors who seem to have grown less reliable. I won't say any names, but if you're specifically interested in that topic, Amanda does talk a little bit in nuance about hormone replacement therapy, and she's a great gateway and conduit to going much deeper on that one. So what are these people usually promoting, the quote hormone specialists?
I guess it depends on what they are. Like I said, the physicians doing it, they're never actually hormone specialists. They're trying to find an easy way to make some money, trying to do, hey, I see a kitty. Some basic, they're just selling prescriptions for testosterone or estrogens and stuff like that. I think the influencer type people or the fitness pros or those types of people, they're just trying to sell either supplements or their programs, which, if their programs are good nutrition, exercise, lifestyle type programs, they don't need to talk about the hormone aspect. But again, it comes back to marketing, I guess. Must be.
And that's what I presume as well, because I both think there's a lot of charlatanery out there, but I also okay, is there a charitable interpretation here where, and it's not to defend it, it's because the hormone balancing is usual claim, and I definitely want to get your thoughts on that language, but it's okay, as you said, if they're getting people to work out more, eat better, and to sleep better, manage their stress better, what have you, and all of a sudden they're feeling better, but like you said earlier, they're also maybe selling supplements. And then of course, people are attributing the benefits, not to all the other big rocks, but to the supplements. We kind of have a problem, right? So again, this hormone balancing is, I've sort of been And I've seen people who I think are actually decent
Yeah.
people who still use that language as marketing language. And then I see total charlatans. But like,
Yeah.
what's the claim where people are claiming to balance hormones? And what hormones are they allegedly balancing?
So yeah, to be honest, I don't know. I mean, and once in a while, I'll even use the term with patients because sometimes there's some nuanced, somewhat truth to it. I always give the disclaimer. Now, this is kind of a quackery term, but if we work on your nutrition, exercise, sleep, maybe they have sleep apnea and we're going to improve their, let's say if it's a guy and they have sort of a functionally low testosterone situation, they don't have a hypothalamic pituitary tumor, but the system's just not working right. I don't know that I would use the term balancing hormones, but something to that effect. I'd say we're going to do all these things, so we're going to improve your hormone system function. Where maybe I use it and I give that disclaimer is more like in young adult females with PCOS, where it's a true disease process. That's the most common endocrine disease in young adult females. But it, to some degree, it really is an imbalance of their androgens, meaning they're kind of quote unquote male hormones, and their estrogens, their female hormones. But it has to do more with, underlying genetic risk, some of the insulin resistant physiology, exacerbated by weight, again, diet, exercise, stuff like that. But there's just a little bit more nuance to it, and it's kind of a balancing situation. It's just that in most of the world, those terms are not appropriate because it's more about our glandular hormone function and communication. And we're looking for disease processes, not balancing. Our bodies, if they're functioning correctly, those things are balanced. But I don't know, that somehow got into this whole, hormone marketing terminology. And so people say, oh, I'm going to balance your hormones because people feel like their hormones are out of whack when stuff's wrong. Well, yeah, if you're stressed out and stuff, yeah, your cortisol's up, but that's its job. So that, I think that's out of whack. Significant, say, anorexia, or high stress or other medications can cause, the whole system to kind of shut down a little bit. Again, that sort of functional hypothalamic pituitary testosterone, adrenal, or just gonadal in general. So for example, the female athlete triad, you're familiar with that? A lot of your listeners may be. So females who are high level athletes maybe aren't eating enough. People who have eating disorders and they have very, very low body fat. Essentially, it's the adipose tissue hypothalamic pituitary gonadal axis that is suppressed, and they lose the stimulation of their ovaries to make enough estrogen, and they lose their menstrual cycles, and that's not good for a lot of things. And so, you could argue, okay, things aren't balanced there, but there's an underlying pathophysiology that we can try to fix. It's that can get a little bit more complicated too, but I don't know. I think there are all sorts of ways where that balancing thing came from. But it's just in the real pathology of endocrine diseases, it's not a really good term. It doesn't really fit, but it's good for the lay public and marketing for sure.
You mentioned the female triad, so didn't get into that very detailed stuff, but a lot of the related concepts. I had a recent conversation with Dr. Sue Kleiner, who's an expert in performance nutrition, and particularly with women. And so she was a recent guest. If someone is interested in that conversation, hit on a lot of stuff there too. Here's the big one we often hear about. Can hormones like insulin, cortisol, certainly growth hormone, estrogen, testosterone, influence metabolic rate and therefore make it more difficult to lose body fat?
Yeah, so this gets really complicated. So a lot of people think that those hormones you just mentioned are not the real drivers of our metabolic rate per se. They all have some influences to some degree, whether and it's not really direct, oftentimes indirect, but our hormones that regulate our appetite and metabolic rate are really the hormones that come from our fat cells, our leptin that you might have heard about. Obviously, now many people are relatively familiar with some of our gut hormones, like our GLP. That's the Ozempics and the Wegovys and the Mounjaros and all that stuff. We've been using those for 20 years for type 2 diabetes, ever since they were discovered in the 80s kind of thing. They play a role along with our nervous system into our hypothalamus. And then there are hormones within our hypothalamus that go up to second order neurons. This gets back to the melanocyte stimulating hormone. There's something called alpha melanocyte stimulating hormone that's being stimulated in the parobiomelanocortin neurons in the hypothalamus. And the other side that has to do with appetite suppression, or et cetera. And it goes up and it does regulate our metabolic rate. Our thyroid hormones certainly have a very important role in our metabolic rate. And there are a lot of factors and indirect factors with that. Testosterone in men is important for, say our muscles, which our muscles play an important role in metabolic rate. So there's always, there are always these indirect ways it can happen. When females go through menopause, now with all this menopause talk out there, a lot of people are saying, oh, that's causing everyone to gain weight. Well, there's some truth to it a little bit. So we know that when females go through menopause, there is a little bit of a trend towards weight gain and a little bit of a trend towards how our bodies store the adipose tissue. And it becomes a little bit more of that central visceral fat storage, which is bad for insulin resistance and cardiometabolic disease, as opposed to the peripheral subcutaneous fat tissue that people may not like, but it's healthy and insulin sensitive and good for that cardiometabolic risk. But it's relatively subtle through menopause compared to what people want to sell it as. And, we also know that menopausal hormone therapy helps to mitigate that a little bit. But again, it is not the driving factor in, say, obesity. Even hypothyroidism, where we know the thyroid hormones have a very important role in our actual metabolic rate for our body, true florid hypothyroidism doesn't by itself just cause obesity. It can certainly exacerbate weight gain in people who are struggling with other things. But the real hormones that are controlling our appetite and metabolism are really a lot more complicated than the famous hormones that people think about, like our sex hormones and thyroid hormones. Now, cortisol, that's an interesting one, because if we have, let's say, a pituitary tumor making too much ACTH, the adrenocorticotropic hormone that I called cortisol stimulating hormone, that's called Cushing's disease. Or if we have a very subtle adrenal tumor that's just cooking a little too much cortisol, that could either cause overt Cushing's syndrome. We can talk about those symptoms, or it can cause what we call mild autonomous cortisol secretion. And it's just, they don't get the true symptoms of Cushing's, which are facial rounding and redness. Some specific findings are gaining fat around the clavicles or behind the neck, purple stretch marks we call striae. And you also have muscle wasting. So you lose muscle in your legs and shoulders. And cortisol also tends to, it does increase appetite. It probably, tends to slow down metabolic rate a little bit. It does cause fat loss of the healthy fat cells oftentimes, while then driving more fat gain into our visceral, liver, abdominal adipose tissue, which is bad for insulin resistance. It in of itself, again, is hard on the muscle, so that's not helpful for our metabolic rate. So cortisol is more complicated, and it does play certainly a role in weight gain. But a lot of times people with very, very severe Cushing's disease, or if they have something we call ectopic Cushing's syndrome, where there's like a cancer somewhere making too much of that ACTH, it's so dramatic, they just waste away. So they don't gain weight. The wasting process of it overrides the hunger and the other metabolic rate issues. So those are, I know that's really complicated for people probably, but that's what we do. And so we think about those things. And so sometimes, we will screen for cortisol excess in those people, or people who have, osteoporosis of kind of unclear reasoning, or diabetes and hyperglycemia that doesn't make sense, or high blood pressure that doesn't make sense. In fact, everyone with high blood pressure probably should be screened for that aldosterone hormone nowadays, but not necessarily excess cortisol. But I know that just went down a rabbit hole. Sorry.
I think it's fantastic. I mean, number one is I think it gets in depth about what is actually going wrong with let's call it dysregulation with a lot of these hormones, or the underlying tissues and causes. So that way people can kind of okay, I'm not experiencing any of that. So at least sort of a theoretical sigh of relief that, okay, I'm probably not dealing with some sort of serious hormonal issue. Okay, relief, genuinely. So what would people be best focusing on as opposed to, and perhaps you could bake this in, inoculate people against the marketing language and the claims about hormone balancing and adrenal fatigue and this sort of stuff?
Yeah, I mean, and I think that just becomes, it's an issue of education. So, people like you, in social media and podcasts, trying to give reasonable public education on health and this stuff. If it sounds like they're trying to sell things, they probably are. If it sounds different than, um, you know, what a real doctor might say, then it's probably not legitimate. If you have real health, physical concerns, then you need to talk to your real doctor about it. And if there's a chance you might have a real hormone disease, you're going to get referred to an endocrinologist if it's most those hormone issues. Maybe OBGYNs will do some of the menopausal hormone therapy stuff. And everyone goes through menopause, by the way. So that's a pretty darn common thing. Well, not everyone. Half the people in the world go through menopause at some point. And a lot of those people get menopausal climacteric symptoms, such as hot flashes. And then they don't sleep well. And then they don't feel well. And then they have brain fog and all the different things that go with it. And, we can treat that. We just need to acknowledge it. And that these things cause symptoms. So I guess for people out there, you just got to, just kind of be on the lookout for those red flags. I mean, so just educating people that adrenal fatigue is a red flag. If someone's telling you have it, run the other way.
All right. You've now talked about visceral fat. So that ties really well into this. You shared a post, I think it was a graphic from someone else, but 1 in 5 adults worldwide with normal BMI had abdominal obesity. How dangerous is this? What's going on?
So this is a big deal. And this is not like a new thing. That was just one new, it was a worldwide cross-sectional study. And that's why it was kind of an interesting publication that literally, you must have just seen it because it was like last week or a few days ago that I shared that. And it fits in line with our American Association of Clinical Endocrinology Obesity Management guideline algorithm that I happened to get involved with a long time ago. And then we just published our brand new one, at least online ahead of print. The real one comes out in November. And what we and other professional societies around the world have really been preaching is that obesity is not a disease of BMI. It's a disease of excess or inappropriately stored adipose tissue that has the risk of or is already causing obesity-related diseases. And so we've known for a long time. When I first gave my talk after the 2016 guidelines were published, I gave my talk at the national ACE is what it stands for. ACE stands for American Association of Clinical Endocrinology. I have some good slides on a lot of the studies showing how, despite the BMI, body mass index of different people, whether it's low, middle of the road, that's kind of generally the healthiest, quote unquote, all the way up. Even within those different categories of BMI, waist circumference is more meaningful as far as the risk of cardiometabolic disease like diabetes, high blood pressure, lipid abnormalities, thus heart disease, and thus mortality or death. And that's much more linear as opposed to BMI. There's so much variability within any given BMI for an individual that it doesn't always work. And we've always kind of known that, but the problem is it became so established for diagnosing obesity that everyone in medicine is supposed to know that it's just a population sort of study. You know what I mean? BMI is very good for evaluating a population because on average, it's really good marker of excess adipose tissue. But for an individual, it's not very good. So these patients who are thin, that means they have relatively low amounts of muscle mass, right? And we know, I assume everyone who listens to your podcast knows muscle's healthy, unless you get it from unsafe practices. You know what I mean? So muscle is very good. So for people who are thin, have low amounts of muscle mass, but then they also have the way they store their adipose tissue, and some of this is genetically related and all that kind of thing, they tend to not store it in those healthy subcutaneous adipose stores, but they store it in the visceral area around their organs and their liver and their pancreas, et cetera. They have even higher risk of all those problems, heart disease and death. And it, it kind of gets confounded a little bit by imagine all the other factors that can go into being thin and having low muscle and really high risk of just disease in general. People who are smokers, people who drink too much alcohol, they're not working out. And so that sort of thing. And there is a term for that called sarcopenic obesity. So a low BMI that, in an athlete might seem great, BMI of 19, 20, 21, 22, whatever. But if they have that plus abdominal obesity, that's a bad thing. They have the highest cardiometabolic risk.
Had Dr. Joey Munoz on recently. We talked about skinny fat. So it's
yes, that's what that is. Yes, that's the old term that that's the layperson term, or even maybe even the fitness or athlete term. That we used to say that back in college too. Before I learned these fancy doctor words that.
And just tying it in for the regular listeners, because like, hey, is this sounding familiar? Joey and I got into that a little bit, but yeah, it's actually quite risky. Now, let's say, I think you did a really good job of framing BMI to the type of people who tend to be a bit more ideologically loaded, and then will go and say, look, see, BMI is a worthless metric, and then it's like, it's healthy to be, you could be healthy at any size. So is that,
yeah. So BMI, again, for most people, it's pretty reasonable to use it as a classification anyways. If people have a BMI over 30, 98% of them definitely have obesity. And then we will screen them or evaluate them with more nuance. We will still do waist circumference measurements. We can do a waist to height measurement. And more importantly, again, this goes back to those ACE guidelines algorithm that I recently published. There's more to it. It's what's on the inside that counts. So everyone does have a different response to not only how they store the adipose tissue, but then what harm does the adipose tissue do? So there are people who can store a lot of healthy fat, and they might have a really high BMI, and they are metabolically pretty healthy at the moment, especially if they're young. And so that's where that metabolic healthy term comes from. And that's where the health at every size sort of unfortunately comes from, because it's actually not a benign state. There's still a high risk of it progressing, but those people do have a genetic predisposition to storing healthy fat, as opposed to some people who meet these lower adipose cell thresholds, they don't expand anymore. And that's some of the first pathology of insulin resistance, and when the fat starts getting stored in the visceral cavity and the liver and stuff like that, and then it becomes this like kind of downward spiral from there. So there's something to it, but that's just an individual basis. But obesity, a BMI over 30, unless you are truly a low body fat, very muscular athlete, and again, not because you took steroids, because that's obviously bad for you, but like I always use the example of a 22-year-old Division I linebacker who has a BMI of 30 and they have a body fat of 6%. You know what I mean? That's not obesity. But most people aren't like that. And so most of the time, the BMI is over 30, and you start getting over 35 and it's a done deal. Like they have excess adipose tissue. Even, NFL linemen, they have obesity. They're just hopefully they're keeping it relatively healthy at the moment through their nutrition, exercise, and all that stuff. But they do have a very high risk of progressing, when they retire, just to use them as an example. And they have to get on the horse and get, work on nutrition and make sure the doctors are supporting their efforts and all that stuff. But yeah, that there's a lot of individual variability, which is why we screen and evaluate for obesity-related diseases and complications. And so somebody with a BMI of 24 with abdominal obesity, they might have some of the worst cardiometabolic disease possible, whereas someone with a BMI of 50 might not have a lot of cardiometabolic disease. Like they might not have much insulin resistance, lipid abnormalities, blood pressure, diabetes, but they do have high risk of other weight-related diseases such as sleep apnea, knee arthritis, obesity-related malignancies, and they still have a risk of progressing to cardiometabolic disease too, even if they have an otherwise very healthy predisposition from their genetics, et cetera, if that makes any sense. So we don't like the healthy at every size sort of mantra. I like to encourage people to understand that, yes, it is what's on the inside that counts. You're not defined by your weight and your BMI. And if you work on your nutrition and exercise, you can be healthy regardless of your weight, but we may still need to help you lose the weight to reduce the other risks too. And it doesn't mean you have to have a BMI of 24 either, by the way. So someone who you weigh 400 pounds and you're healthy, you will garner a lot of health benefits and future risk reduction by losing 10% of your weight, which in that case, it's 40 pounds. And that may not sound like a great thing to get down from 400 to 360, but that's a huge advantage for your health and future risk. We know that for sure.
This episode is brought to you by Just Bite Me Meals. I work long days and I won't compromise my client experience or sacrifice my workout, sleep, or nutrition. So I needed a quality and reliable meal prep service so I could save time on cooking and shopping and have more time for the stuff that matters. Net out the cost of groceries and the service isn't as much as you might think, and regular impulsive food delivery apps, eating out, that costs way more anyway. I get more meal variety and less dishes to clean, and I've been referring clients to Just Bite Me Meals for a long time, and I recently started ordering myself. Food is great. The beef brisket tacos are my favorite so far, and there's a lot of menu choice. Your calories and macros are listed. The portions are great. You can order custom meals. They deliver to your door, or you can pick up from their storefront. And I'm sorry to listeners outside of Alberta, but Just Bite Me Meals is currently just in Edmonton, Calgary, Grand Prairie, and Fort McMurray. Ordering from Just Bite Me Meals made my life easier instantly. And you can get 10% off on all your orders using my code, Andrew Coates Fitness, all caps, on their website. That's Andrew Coates Fitness, all capitals, or go to the link and the code in the show notes. You mentioned knee arthritis, and I don't think I've asked anybody this. Do you have, because again, you're an obesity specialist, do you have pretty good data or strong anecdotes about what are the musculoskeletal injury, let's say degeneration risks with walking around, with higher BMIs, obesity?
Yeah. So the data really are mostly around knee arthritis. That's the big one. So obesity, the higher BMIs are definitively associated with the more risk of knee osteoarthritis. And then we know for sure, especially from like bariatric surgery studies, how much better knee arthritis can get from substantial weight loss. Again, 10, 15 or more % weight loss. And then we also have good trials for medications. For example, semaglutide, which in the study was Wegovy because it's at 2.4 milligrams, and that's the obesity indication, but it's also the one that's called Ozempic for type 2 diabetes. And that showed substantial benefits for knee arthritis in people who have it. We also know that weight loss not only helps the knee arthritis symptoms, but then it also helps the recovery from, say, a knee replacement. And then, of course, it's easier to do all the things that they have to do to recover even better with their exercise, their physical therapy afterwards. So yes, obesity definitely drives knee arthritis. Weight loss, no matter how it's done, is good for knee arthritis. There was even some hints that, because these GLP hormones have some anti-inflammatory benefits, that maybe there's even more to it. I don't want to get into that because I'm not the ortho guy, but there's some science there that maybe there's some benefit beyond just the weight loss, kind of like with the cardiovascular risk reduction. It's not just the weight with these medications.
And I can't pin down a specific claim, but I've seen some rhetoric. Again, it tends to be that kind of the more extreme end of the health at any size crowd that, suggests there's no increased injury risk or degenerative risk with higher levels of obesity. I think that just is so counterintuitive that.
Yeah, I mean, that's just counter to the evidence. I mean, we have it's pretty strong evidence for knee arthritis. It's in our guideline. I think there's at least a small section on it. So,
and I don't think it's bad. I think you can kind of extrapolate even further to suggest that there's probably increased risk of other sort of musculoskeletal issues. But
just physical function in general. So we often, in fact, kind of to the akin to our algorithm and talking about staging the severity of disease based upon the weight-related diseases and complications. You may have heard about this Worldwide Lancet Commission, which also kind of tried to do the same thing. We don't fully agree with some of the semantics and definitions around it, but basically they talked about preclinical obesity, which we would call a stage 1. Like they do have excess adipose tissue and risk of all the complications, but they actually don't have any of them right now. So they are a healthy obesity, but they have the risk of it, right? And then we stage it then 2 and 3 for kind of moderate, mild to moderate, and then more severe. They have what they call preclinical, and then they have clinical obesity. Basically, for listeners, it's the same basic concept, but they talk a lot about the physical complications directly from the excess adipose tissue. And a lot of that is literal physical well-being. And so it's not just knee arthritis, but people being able to get around. I know, so my little taller brother, Spencer, is, a social media guru, and he does a lot of posts a lot. And I know he's made posts quite frequently about how, people always think that exercise is the key for weight loss. And that's not actually true. Exercise is just really good for you. We can get into that more later, but there are a lot of people who literally physically cannot exercise because of their obesity. So they have to, have the nutritional prescription and maybe the medications or the surgery to help them lose the weight so that they can exercise because of their physical limitations due to obesity. So, that's a pretty slam dunk issue. It's the musculoskeletal issues with obesity. It's really not even up for debate. It's not at all, to be honest.
And to your point, I've worked with people from all populations, but some of the people who've had the greater degrees of obesity, yes, some of the just everyday routine stuff of movement, getting around, accessibility, etc. These things can be pretty detrimental, and that can affect you physically, but it also affects people emotionally too. So
that's a great point. So when we talk about these obesity-related diseases, not only do we have the cardiometabolic stuff that a lot of people think about, we have the physical issues and the limitations, but we also have the mental, emotional, and some of those complications, and something called internalized weight bias. So, the society has this stigma and external bias onto people who are struggling with obesity. And then that turns into what we call internalized weight bias. And it's like self-blame, and it's a vicious cycle, and it makes it harder to then treat and have better outcomes. And so we have to always address the mental health aspect of everyone, really, but include, especially people with obesity and related disease.
It's already out by now, but I just recorded an episode with Dr. Ben Ryan, and we talk a lot about the health problems associated with isolation, but I don't think it's much to extrapolate here that you'd probably know this data if people are struggling with obesity, and then there's the emotional side of it, and then they tend to, hide from the world, especially if there's disordered eating or fear of being seen eating anything. So then they may, I presume, hide a bit more from the world, isolate themselves a bit more. And now not only are you dealing with all the real effects, metabolic health effects, cardiorespiratory effects of obesity long-term, but now you may be compounding them by less social interaction, which also is really bad for us.
That's a great point. Great insight. I agree full-heartedly. Absolutely.
Okay. With just a couple of minutes, sort of a short one, is there any evidence that diet drinks, like my diet White Monster here, which I love, are hard on livers?
So here's the bottom line with that. And this, I wrote a counterpoint to that concern many years ago, and we have to keep sharing the data on this since then. The observational data, meaning correlation studies, population studies, they do always suggest there is a correlation between diet drinks as well as sugary drinks and obesity and obesity-related cardiometabolic disease, including the liver. However, every single interventional study done that I could find when I did my review and that I keep following along the way shows that replacing sugary drinks with diet versions is good, just as good, sometimes even better than water. And I think I posted about that because everyone said, oh, there's another observational study correlating diet drinks being even worse than sugar drinks for the liver. But we have plenty of data to show that is exactly the opposite. Improved liver health with diet drinks, And my one other little nugget to that is that I think people miss, but I put it in my counterpoint several years ago, is that some of the best nutritional data we have are when people are put on meal replacement drinks, right? So high intensity, essentially protein drinks with essentially vegetables. It's a pretty intensive dietary intervention, but it has the best data for weight loss, diabetes, remission, liver fat reduction, all that stuff. Guess what those protein drinks are flavored with?
Artificial sweeteners.
They are. So anyways, that's the actual interventional data, and it drives us all insane, and it's confusing to doctors and public health officials alike.
And I think your brother over the years has done a wonderful job of tackling artificial sweeteners. And I don't think anything makes people crazier. I admire your brother for, God, he'll talk about this frequently, how like he'll advocate for the full spectrum, diet and exercise, but then like GLP-1 agonist medications, bariatric surgery, depends on the circumstance. And if he may say something about or artificial sweeteners, and when he says certain things, then people go completely ballistic.
Yeah.
Especially if he doesn't manage to fit in the same breath that he's an advocate for exercise and good nutrition. People lose their minds.
Especially with his big social media following, and he's so into that stuff. He has a lot of people. I don't have as many people who get all disgruntled because it's a smaller following, and I think they're just more like a little bit more niche and into the science-based health and whatever, and maybe more of like real patients. But and then he'll make a post that says something about the Joker saying, "Oh, talk about diet, exercise. Nobody bats an eye. Mention how diet drinks are okay, and everyone loses their mind." Every time.
He's great at poking the bear. If you guys want to listen to that episode, shoot me a message or just scroll through the library. He's great. He's been on a few times, including recently. But everybody can follow your great media at Dr. Karl Nadolsky, at Dr. Karl Nadolsky. Anything else you want to send people to?
No, I think, obviously we have our Docs Who Live podcast, which is, I think pretty well in line with what you're doing, and Amanda Thiebe and Jen Gunter, like we're all kind of in the same circle trying to fight the medical and health misinformation out there. I think if people are interested, if there are any health professionals interested, check out our American Association of Clinical Endocrinology 2025 obesity management algorithm that was just published online. It'll be published in print coming up soon. You can check out my counterpoint to the diet beverage issue and obesity that was in Endocrine Practice in 2021. I don't know. I'm gonna have to make an update to it because I feel like I have to update it with a post every month because of what you just said. So those are some resources I think you can have.
This has been fantastic.
And if you live in Michigan and you need an endocrinologist, my clinic is called the Diabetes and Endocrinology Clinic at the gym in Holland, Michigan.
Fantastic. This has been an incredible deep dive, nuanced conversation about this stuff. And I think for the fitness professionals listening, if you guys are tempted with some of this language, approach it with caution like we did. There's definitely some charlatan red flags dressed up there, but I still think a lot of the people who might be tempted who have good integrity are still, it's really about the sleep. It's really about the nutrition. It's really about the training. But I think we do have to actually watch the marketing language at this point because it's been hijacked by the bad faith actors. Guys,
right. That's the problem. Like holistic medicine, we're all supposed to be holistic, but then the quacks took it over. Now it sounds quackery too.
Absolutely. So everybody, please go follow Karl. And I appreciate you guys tuning in every week to continue to support the podcast so I can bring you industry leading guests on highly educated people. Right. So it's been a joy. Thank you so much.
All right. Keep up the good work.